An experiment, a certain gene product is known to stimulate the production of a particular hormone synthesized in the liver. This hormone, when present in increased amounts, downregulates the expression of a divalent cation transmembrane transporter located on the baselateral membranes of enterocytes. Mutation in the gene product has been linked to certain abnormalities in affected patients. Such individuals may present with darkening of the skin, cold intolerance, excessive urination, and weight loss. Patients may also present with symptoms of cardiovascular disease as a result of this disease. Which of the following would be likely finding in affected patient? A. Preload increased cardiocontractility, decreased afterload increased. B. Preload decreased, cardiac contractility decreased, afterload decreased. C. Preload increased, cardiac contractility increased, afterload increased. D. Preload decreased, cardiac contraction unchanged, afterload increased. E. Preload increased, cardiac contraction increased, afterload decreased. The correct answer is D. A decrease in ventricular preload, a normal force of contraction, and an increase in afterload is typical in patients with restrictive cardiomyopathy. The vignettes above describes primary hemochromatosis, a disorder of iron metabolism. The HFE gene, hemochromatosis gene, product regulates the production of hepcidin, a hormone synthesized in the liver. Hepcidin is the chief regulator of iron absorption in humans, and a decrease in this production upregulates the expression of ferroportin 1, which transport iron from the enterocytes into the circulation. Mutations in the HFE gene modulate the levels of hepcidin and the ferroportin as implicated in hemochromatosis. Such patients typically represent with problems arising from excessive deposition of iron in tissue, such as the pancreas, diabetes mellitus. The skin pigmentation, the thyroid, hypothyroidism, and the heart restrictive cardiomyopathy. In restrictive cardiomyopathy, ventricular compliance is reduced due to infiltrative fibrosis, and the myocardial cannot stretch maximally in response to the influx of blood during diastole. This leads to a decrease in the preload. Preload and diastolic blood volume. Factors that increase preload include ventricular compliance, central venous pressure due to increased total blood volume, increased venous return, and decreased venous compliance, increased artery contractility, aortic pressure, decreased heart rate. Conversely, factors that decrease preload include decreased ventricular compliance, decreased central venous pressure due to decreased total blood volume, decreased venous return, and increased venous compliance, decreased artery contractility, decreased aortic pressure, increased heart rate. In restrictive cardiomyopathy, diastolic function is impaired, but the systolic function is preserved. Therefore, cardiac contractility remains normal. Factors that increase cardiac contractility include increased heart rate, Bowditch effect, increased afterload, MRAP effect, increased preload, increased sympathetic stimulation, for example, exercise anxiety, thyrotoxicosis, increased parasympathetic inhibition, use of inotropies. Factors that decrease cardiac contractility include decreased preload, increased sympathetic inhibition, increased parasympathetic stimulation, disorders of the myocardium, for example, myocarditis, dilated cardiomyopathy, use of beta blockers, calcium channel blockers. Due to the decrease in preload seen in restrictive cardiomyopathy, there is a reduction in stroke volume and a subsequent reduction in cardiac output. Stroke volume and diastolic volume and systolic volume, cardiac output, stroke volume times heart rate. The chronic reduction in cardiac output stimulates the activation of the renin angiotensin aldosterone system, RAAS, as well as the sympathetic nervous system, increase the production of angiotensin II and catecholamines, lead to salt and water retention and peripheral constriction, thereby raising the total peripheral resistance afterload. Factors that increase afterload include peripheral vasoconstriction, increased systemic vascular resistance, increased mean arterial pressure, left ventricular outflow tract obstruction, aortic stenosis, hypertrophic cardiomyopathy, use of alpha-1 antagonists. Factors that decrease afterload include increased peripheral vasodilation, decreased systemic vascular resistance, increased mean arterial pressure, use of vasodilations. Option A, an increase in ventricular preload, a decrease in force of contraction, and an increase in afterload are typical seen in patients with dilated cardiomyopathy. Option B, a decrease in ventricular preload, a decrease in the force of contraction, and a decrease in afterload is seen in patients with septic shock due to widespread vasodilation resulting from bacterial endotoxemia. Option C, an increase in ventricular preload, a decrease and an increase in the force of contraction, and an increase in afterload can be seen after fluid infusion. As total blood volume increases, while venous returns to the heart increases, and the preload is increased. An increased preload leads to stretching of the myocardial fiber to generate a strong force of contraction, Frank-Starling mechanism. The increase in vascular tone resulting from the fluid infusion results in an increased systemic vascular resistance. Afterload, an increase in ventricular preload, an increase in the force of contraction, and an increase in afterload can also seen in left ventricular outflow tract obstruction. For example, aortic stenosis. Option E, an increase in ventricular preload, an increase in the force of contraction, and a decrease in afterload can be seen during exercise. The afterload decreases due to sympathetic stimulation of beta-2 receptors within skeletal muscle, resulting in vasodilation and a fall in systemic vascular resistance. Learning objective. Ventricular systolic performance is determined by the interaction of preload, cardiac contraction, and afterload.